please feel free to use this presentation as a resource and to check out all of those various links that I've included in the presentation. I also will have the chat box in front of me here so that I can see if anyone has any questions. Feel free to put things in the chat as you're thinking about them, put any questions out there. You can also use the raise hand feature if you have that as one of the reactions so that we can see if you have a question that you'd like to verbalize. All right, so let's kick things off with HIV basics and some Wisconsin specific data. First of all, what is HIV? If you have any thoughts about what HIV is, feel free to drop them in the chat now. Just like to hear a couple of different things or see a couple of different thoughts. What do you think HIV is? I'm sure you've all heard of it before, so just, yep. Yes, the virus that can lead to AIDS. It's a virus that affects the body's immune system. That is right. Okay, well, it is the acronym for human immunodeficiency virus. It is, Nicole, you're correct. It is a viral infection that attacks the immune system by killing, it's actually T cells and CD4. So those are white blood cells that are in the immune system. It attacks the cells by kind of replicating itself. It attaches to the cell, and then it manages to replicate itself and kind of take over the body's immune cells, those CD4 cells. There is no cure for HIV, but it is very much so treatable with medicine. And we'll talk a lot more about that later on in the presentation. So how is HIV transmitted? Well, the virus can be present in sufficient quantities in a person's blood, semen, vaginal secretions, breast milk, brain and spinal cord fluid, amniotic fluid. So if the person living with HIV has not been taking medications, is not treating the virus, then the virus can replicate quickly and it will show up in these listed bodily fluids. And it is not transmitted through saliva, sweat, tears, urine, or feces. So that's important to understand that it won't be present in every bodily fluid, but it will be present in these ones that are listed here on this slide. So the main modes of HIV transmission, if you think about how HIV is present in those particular bodily fluids, that means that there are certain ways that HIV can be transmitted by coming into contact with those fluids. One of those is sexual contact with a person who has HIV, who has a detectable viral load. And what I mean when I say a detectable viral load is the person is not currently treating their HIV with medications. The virus, if left untreated, can replicate and continue to be present in the body for many years. It can sometimes take well over a decade before a person's HIV would advance to stage 3, late stage HIV or AIDS. And so during that entire time, if a person is not taking medications or treating their HIV, they can pass the virus on to sexual partners through sexual contact, and that can include oral, anal, or vaginal sex. When I say sexual contact, I'm including all of those various forms of sexual activity. Another way that HIV can be transmitted is through being stuck or pierced with a sharp object that has blood that has HIV present on it. So that could be through a tattoo needle. It could be through a syringe, a needle that's used to inject drugs. It could be through a blood transfusion. Although, of course, there are safety measures that are in place to avoid or prevent those things from happening. That is another mode of transmission for HIV. It can also be transmitted from a woman living with HIV to her baby during pregnancy, birth, or breastfeeding. So who is at risk for HIV based on those modes of transmission? Any thoughts? Anyone want to throw out a thought on who might be at risk for HIV?
I was going to say anyone, someone already said this in the chat, but anyone who used intravenous drugs, folks who might have unprotected sex. I know at one point with early on with the HIV crisis, there was infection transmission by blood donation or blood transfusion.
Okay.
But that was early on, right?
Right, and of course, yes, and there are protections now in place to prevent that. But yeah, those are all definitely good points as far as modes of transmission go. I do want to kind of reframe this question a little bit, and I want to throw out there that anyone could be at risk for HIV. Because we don't really know necessarily what's going on in people's lives. And so, yes, there are various communities and folks that may be at higher risk than others, but the reality is that anyone could be at risk for HIV. And the CDC actually recommends that every person between the ages of 13 to 64 be tested for HIV at least once in their lifetime. Unfortunately, there are a lot of medical providers that don't offer up an HIV test to a lot of their patients because they assume that, oh, this person can't possibly be at risk for HIV. I would argue from my experience that that's part of the reason why about 16% of the population in the US that is living with HIV is still undiagnosed, because we aren't offering testing to anyone. Really, anyone could be at risk. And so I think as we're increasing the availability and the accessibility of testing, it's really important to remember that the person in front of you may be at risk for HIV and you may not know it. So offering testing, offering education is very important. With that being said, there are communities that are disproportionately impacted by HIV and have been since the start of the HIV epidemic, when it was first discovered in the early 80s. So gay and bisexual men, people who inject drugs, women of trans experience, and Black and Latinx communities are disproportionately impacted by HIV. And certainly we know about the risks associated with various modes of transmission, but there's another layer going on here that particularly would make people in these communities disproportionately impacted by HIV, and that's social determinants of health. So it's not to say that folks who are in those communities that are disproportionately impacted are doing anything that is necessarily more risky than other people. But the reality is that social determinants of health play a huge factor in disparate health outcomes for different communities. So as Sierra in the chat pointed out, it is partly a lack of healthcare and poverty. Those are definitely good examples of social determinants of health. So when I talk about social determinants, I'm talking about social environment. What is the environment, the lived environment that a person is in, the physical environment. Are there clinics nearby? Is the environment, is there transportation? Is it easy to get around physically in the person's environment? Health services. Does the person have insurance? Does the person have access to quality health care? Structural and societal factors. Poverty is definitely one of those. Education is one of those. Jobs. So social determinants of health are shaped by the distribution of money, power, and resources throughout local communities, nations, and ultimately the world. And so when we look at the data that I'm about to show you on what the HIV epidemic looks like in Wisconsin and who's disproportionately impacted, I really want you to think about it in terms of how social determinants of health play a role in why certain communities and areas are disproportionately impacted by HIV. So let's take a look at some of this data. So the Wisconsin HIV program releases data on the HIV epidemic in Wisconsin every year. And the most recent data we have is for 2019. We do expect that the 2020 data would be released sometime this summer. It's usually around June, July, or August. And certainly the COVID-19 pandemic will have impacted the HIV data for 2020 in a way that we haven't seen in any of the previous years worth of data. So that's something to keep in mind. So when I'm talking about 2019 data, obviously this is pre-COVID. So the majority of new HIV cases were identified in Milwaukee and Dane counties in Wisconsin. And you can see here that this map shows the number of new HIV diagnoses in each county in the state. So what you see here is there are several counties that had no new HIV diagnoses at all, whereas other counties had a lot of new HIV diagnoses compared. So among those two, there were 214 new HIV diagnoses in 2019. 32 years was the median age of the person who was newly diagnosed. 78% of those diagnoses were people who identify as male, and 68% were people of color. Here are some of the trends that we're seeing among HIV diagnoses in Wisconsin. So the number of new diagnoses has slowly declined over the past 10 years. We can see that the first case was actually identified in 1979, and that was after the fact. We actually didn't report on the first case of HIV until 1982, but then it went up dramatically throughout the 80s to a high of 588 in 1990. And then it slowly went down and has kind of plateaued for the last decade, almost 20 years. It's plateaued to be around anywhere between 200 and 270 new diagnoses of HIV each year in the state of Wisconsin. So a couple of things to think about in terms of this trend. Number one is the introduction of treatment for HIV is what really significantly lowered the number of new diagnoses in the late 90s. So that's how we went from 493 diagnoses in 1994 down to 265 by 2000. It's because treatment became available in a widespread and effective way in the late 90s. So the by far most significant mode of HIV transmission in Wisconsin is male-to-male sexual contact. So in 2019, out of those 214 new HIV diagnoses, 140 could be attributed to male-to-male sexual contact. 44 were attributed to heterosexual contact, and I really don't like that that way of describing it, honestly. So we're thinking of different ways to describe that mode of transmission, but that's what's in the report right now. That implies basically that a penis came into contact with a vagina. And so that was how the HIV was transmitted among 44 people. Injection drug use attributed the remaining diagnoses of HIV in the state. So we are fortunate in the state of Wisconsin that there is a pretty solid network of syringe exchange services throughout the state. And syringe exchange services allow a person who uses drugs to go in and access clean needles by exchanging ones that they've already used for new clean ones. And that service is primarily provided by Vivint Health throughout the state, but it's also provided by local health departments as well. And Vivint Health has also done a great job of increasing access to Narcan, the overdose reversal treatment throughout the state. So with that network in place, we have been able to significantly reduce the number of HIV transmissions that are attributed to injection drug use. So something to consider when we talk about health disparities and HIV health disparities specifically is that racial and ethnic minorities make up just 18% of Wisconsin's population, but accounted for 68% of new HIV diagnoses. So in 2019, the percentage of new HIV diagnosis by race and ethnicity, 47% identified as Black, 15% identified as Latinx, and 6% identified as either Asian, Native Hawaiian, Pacific Islander, or multiracial, and 32% identified as white. So this image of HIV that's sometimes portrayed in films or pop culture as being a white gay disease is really not accurate and isn't reflected in reality. And again, when you consider why is it that people of color are disproportionately impacted by HIV, I refer back to the social determinants of health. And all the things that many of us know are true to the experiences of people of color in Wisconsin, such as segregation, redlining, years of poverty, and generational racism that folks in those communities went through in the state. So when we talk about HIV, we also want to talk about how are we doing in effectively treating the virus. And when we effectively treat the virus, we get to a point where a person living with HIV is virally suppressed. And I'll get a little bit more, I'll go into a little bit more detail about viral suppression in a little while, but one of the things I'd like to note on this slide is that 75% of the people living with HIV in Wisconsin were virally suppressed in 2019. So what you're looking at on this slide is what we call the HIV Care Continuum. HIV is a reportable disease in Wisconsin. So anytime there's a new diagnosis, it does get reported to the state health department. In the same way, like I'm sure you all know, COVID has been reported to the state health department. And we also do get lab results for people living with HIV reported to the state health department as well. So with that information, we're able to identify the numbers of people living with HIV who are in care, who are retained in care, and who are virally suppressed. So it's a bit of a concern that only 81% of the people that have been identified as living with HIV are in care. That means that almost 20% are not. And then when we think about it further, go down the continuum, and when we talk about retained in care, which means that a person has gone to at least 2 medical appointments each year, that's only 60% of our population of people living with HIV. So 40% are not retained in care. And then that explains essentially why our viral suppression rate is at 75%, because a person has to be in care really in order to be virally suppressed. You can't access the medications to treat HIV unless you're in care. So this is without a doubt an area of improvement for us in the state as an HIV program. We really want to see these numbers get better. And it's a lot of the focus of our work right now is working on interventions to fully engage people living with HIV in their care so that we have higher numbers of people who are retained and who are ultimately virally suppressed. So this slide gives you an idea of HIV prevalence. So we do also keep track of folks who are living with HIV who move into the state and who leave the state. So with the data that we have, we can say that in 2019, there were a total of 6,749 people living with HIV in Wisconsin. So 759 people living with HIV actually moved to another state during 2019. And 218 people living with HIV moved into Wisconsin. So that's on top of the 214 who were newly diagnosed. And 75 people living with HIV died during 2019, but I do want to point out that that is death from any cause. So not all of those 75 died due to complications related to HIV. They may have died in car accidents or other things that had nothing to do with their HIV. So prevalence, HIV prevalence is just the total number of people living in the state with HIV. That's different. This map is slightly different from the earlier map I showed you of people who were newly diagnosed. So we see that people are living with HIV in almost every county in the state of Wisconsin, with the exception of Pepin, which as of 2019 had no one living with HIV identified there. But every other county has at least one person living with HIV in it. This certainly speaks to the need to have services that can reach anyone, anywhere in the state. On top of that, we also once again recognize that the majority of people living with HIV are in Dane and Milwaukee County, or in generally the southern and southeastern part of the state. And so when we think about the equitable distribution of resources to address HIV, we want to make sure that most of our resources are going to those areas. So here are some links to some really good resources that you can take a look at later. We have our annual HIV surveillance report, which goes into a lot more detail than I was able to go into during this presentation. We also have a 2-page summary of the surveillance report. So if you're just looking for like something to show people that's really quick and kind of gets to all of the most important points, that 2-page summary is a really good tool for that. And then also the HIV.gov website has a whole section on what is HIV and AIDS, and it goes into a lot more detail about the characteristics of the virus itself and the different stages of HIV that a person will go through that I wasn't able to get into in this presentation. So now I'm going to pivot over to talking about HIV-related statutes. And again, I'm not going to cover every single statute on the books related to HIV, but just some of the highlights that I think it would be good for you to know in your roles. So first of all, it's important to know that all of the HIV-related statutes are in Chapter 252 of the Wisconsin statutes, and that is everything related to communicable diseases. So I have highlighted here some of the specific sections within Chapter 252 that deal with HIV. So if you just go to the Wisconsin State Legislature website and you're like, I want to really read all of the statutes related to HIV, this is the page you're going to want to go to, Chapter 252. And what do the HIV statutes do? Well, they're intended to balance the needs of the individual and society. So ideally, that is going to protect the individual and protect members of the general public. For the individual, that means we have opt-out verbal informed consent required for all HIV testing. Penalties are imposed for unlawfully disclosing HIV test results, and penalties are imposed on healthcare providers who discriminate against people living with HIV. For the overall society, for the general public, some of the protections in the statutes include blood, plasma, and organ donations are always tested for HIV before they're given to the general supply. And positive HIV test results are always reported to the state HIV program, as I discussed earlier. It's a communicable disease that's reportable, just like so many others. And it allows us to then keep track of the data related to HIV in the state, how it spread, who is disproportionately impacted, and then also to allow local health departments to follow up on new HIV cases by talking to partners using what's called partner services. It's very similar. I'm sure many of you have heard a lot about contact tracing for COVID-19. It's the same idea for HIV. We talk to the person who was diagnosed. We get some information about their sex partners, and then 100% anonymously, local health department staff would reach out to those sex partners and encourage them to be tested for HIV and STIs. So when we talk about consent for HIV testing, the Wisconsin statutes require opt-out verbal consent. So that means that the provider always has to notify the patient that they will be tested unless they decline. The patient does not need to sign anything, and the provider has to document in the patient's medical record if the patient consented or declined. You may also know that we have some state-funded rapid HIV testing sites throughout the state. And those sites actually do have to have a signed written consent. And that's just part of the requirements of our state program. It's not that they couldn't do verbal consent, it's that our program, as part of our funding, is asking them to have that written consent on file. So when we think about consent for HIV testing, when the provider offers information, they have to talk about the meaning of HIV test results, the reporting requirements, the treatment options, and services provided to HIV positive individuals by AIDS service organizations and other community organizations. They have to give the patient the opportunity to ask questions and tell the patient that other healthcare services cannot be denied if they do not accept the HIV test. Last but not least, they should verify that the patient understands that HIV testing will occur and that they voluntarily accept it. So this is what verbal consent should include when a provider is having that conversation with a patient. When we think about adolescents, the age of consent for HIV testing is 14 in the state of Wisconsin, although people younger than 14 can also access HIV testing services without necessarily having a parent or guardian. The statutes are not specific in saying that a parent or guardian needs to be involved for people under 14. It just says that the age of consent for HIV testing is 14. So the person who consents to the test also has access to the test results. So if the parent or guardian is involved and consents to the test, then they would also have access to that test result. Consent for treatment of HIV is a little bit different. So people under the age of 18 cannot consent to HIV treatment without a parent or guardian. And that does include PEP and PrEP. So treatment, this statute is quite outdated, I would say, because it was put on the books before PrEP and PEP were a thing. And when there was understanding among people in the healthcare field that HIV treatment had high toxicity, particularly in young people, that is not true anymore. And certainly with the advent of PrEP, especially pre-exposure prophylaxis, it's important to understand that PrEP has been proven effective with minor to no side effects in adolescents. So this statute is a concern, but it is on the books. So it's just something you need to be aware of. And people under the age of 18 can consent to STI treatment without a parent or guardian. HIV treatment is treated differently, unfortunately. Again, like with so many other things, it's important that protective services mandated reporting be considered. So if someone tests for HIV, if you're the tester or you're working with a younger person, that if there's any concern that the tested youth is being physically or sexually abused, that does need to be reported to Child Protective Services. And reproductive health staff and STD HIV testers are able to maintain the confidentiality of the youth if they are in a consensual sexual relationship with a peer. So that's where there's a bit of a caveat to that. Individuals must provide a written authorization to disclose their test result to another person or agency. So if an agency tests someone for HIV and the person does test positive, then in order to share that positive test result with another agency, what's called a written authorization for release of test results has to be on file, and it has to include these items: the name of the person, the specific information to be disclosed, the name of the person authorized to make the disclosure, the signature of the person who was tested, the date that the authorization was signed, and the effective time period. So if you're working with a client who maybe got tested for HIV and another agency did the test and they want to share that result with you, make sure that there is a written authorization. Of course, the client can share their test results with you without having a written authorization. They have the right to do that. But if it's an agency that's sharing it from another, outside of your specific agency, they really do need to have this written authorization on file. The only exceptions to that are these legally allowed disclosures. So I won't list all of these, but they are on this slide. And there are a lot of various legally allowed disclosures. The most significant one is the healthcare provider or the agent of a healthcare provider. So if it's someone who tested positive and they're going to someplace else for care, then that would be a situation where to effectively provide care to the person, the healthcare provider can share that test result with another healthcare provider. So here are all the resources that are out there related to statutes. So again, we'll send you these slides after this, and you'll be able to access all of these resources by clicking on these links. So right now, I'm going to take a quick 5-minute break. So if you all want to come back at 2:49, we'll continue then with our presentation and look at stigma and language. See you at 2:49, everyone.
Thanks, Jacob. We'll see you in a couple minutes, everyone.
All right. Welcome back, everyone. It's been 5 minutes. So we're going to go ahead and get started again. So the next section of the presentation really goes into HIV stigma and language. So when we think about HIV-related stigma, what are we talking about? We're talking about negative beliefs, feelings, and attitudes toward people living with HIV, their families, and people who work with them. So when I talk about stigma throughout this presentation, that's really what I'm referring to, are these negative beliefs, feelings, and attitudes. Stigma has been acknowledged by the federal government and several international HIV agencies as being a major challenge to addressing the HIV epidemic around the world. So the national HIV strategy that was updated recently to 2020 calls out stigma specifically and says one of the goals is to reduce stigma and eliminate discrimination associated with HIV status. Since this presentation was created actually in January, there was a new national HIV strategic plan that was released by the federal government. And that plan actually talks even more about stigma and the need to address stigma in order to effectively address HIV. So when we think about stigma, there are really 4 elements that we're thinking about here. And this doesn't just apply to HIV, but when I'm talking about it in this slide, we're going to think about it in those terms. So one element is labeling, which would be assigning an attribute to a person, place, thing, or event. So an example of labeling in the HIV world would be calling it a gay disease or saying that it's a death sentence. Those are examples of how labeling shows up in HIV stigma. Stereotyping, it's a belief that's primarily negative about a group. So in the HIV context, that would be all gay men have HIV, or gay men are responsible for spreading HIV, or people who inject drugs are responsible for HIV. Those are the types of stereotypes that we have out there that result in HIV stigma. Prejudice is another element, and that's a negative preconceived notion or belief that leads to an emotional reaction. An example of prejudice would be a doctor who is afraid to provide services to a gay man because he might have HIV. And we did see a lot of this kind of prejudice, especially in the early years of the HIV epidemic, when many healthcare providers would refuse to see or treat gay men because they assumed that they would have HIV. The last element of stigma is discrimination, and that's behaviors or actions that are in agreement with a belief or negative emotional response defended or encouraged by society. So that would be avoidance or withholding healthcare or employment and housing opportunities for people living with HIV. There are also some discriminatory HIV statutes on the books in some states that could result in prosecution of people living with HIV if they have sex with partners without telling them about their HIV status. Stigma, of course, is a multi-level construct, right? So there's the individual level, how stigma affects the individual, and that can show up in things like self-stigma, low self-esteem, or concealing. So a person may be afraid to talk about their HIV status because they don't want to deal with the reaction of the other person, whether that be a family member, someone on a dating or hookup app, or a healthcare provider. Interpersonal stigma results in rejection and discrimination. So that would be the reaction that I was referencing earlier. If a person talks about their HIV status and they are rejected by whoever it is that they're sharing that information with. And then structural, so things like state policies and institutional practices that can have stigmatizing elements embedded within them. That could also be here on the presentation when you're thinking about societal level conditions, cultural norms, and institutional policies and practices that constrain the opportunities, resources, and well-being of the stigmatized person. So ultimately, stigma has an impact on our response to the HIV epidemic. HIV prevention and care efforts are negatively impacted. People who feel stigmatized are 4 times more likely to report poor access to care. They have less willingness to take an HIV test, less openness to discuss their sexual risk, and they're less likely to disclose their status to potential sex partners, significant others, providers, family members, or other people who could potentially be supportive. The impact of stigma on people living with HIV shows up in multiple ways and venues. So it shows up in the healthcare system, in government, in media and entertainment, and in relationships. And fortunately, we do have resources out there to help people living with HIV access all of the healthcare services that they need. But if you're feeling stigmatized, at that interpersonal level or at the personal level, where you feel self-stigma, that alone could prevent you from accessing healthcare services, even if you have all those resources available to you. And media and entertainment has really done a terrible job over the course of many years of stigmatizing people living with HIV. It's only been more recent that we've started to see more nuanced and diverse stories of people living with HIV presented in media on shows like Pose, for example. But in so many ways and for so many years, HIV was represented as this horrible death sentence and was often sensationalized on daytime talk shows and other news and entertainment venues. So the question that always comes up whenever we're talking about stigma is that, yes, we get it. We understand why it's a problem and why it's a concern, but what can we actually do about it? Because it can seem really daunting to try to make an impact at such a high level when we're talking about stigma. But I think there are some realistic things that people in the helping professions can do to address stigma. One of those is to use compassionate, person-centered language. So we recognize, and I think many of us here who are watching this probably are well aware, that it takes time and practice to learn new things with language. And that's not just with HIV, that can be when talking about people in general. People want to feel respected, they want to feel heard. And using person-centered language is one way to do that. It is okay to make mistakes. They are learning opportunities. No one is trying to be the language police or shut you down. But if a person does acknowledge that, hey, I would prefer to be addressed this way, or what you said kind of made me feel a certain way, could you please refer to it like this? That's a learning opportunity. I know it can feel like an attack sometimes, but if you think of it as a learning opportunity, apologize and use what you learned going forward, it can really make a difference when you're working with clients. Develop genuine, meaningful relationships with clients to ensure they feel safe and welcome in healthcare settings. Building trust is a huge deal when we're talking about people living with HIV and people in communities that are disproportionately impacted, because many of them have had horrible experiences in the healthcare world and working with service organizations over the years. Participate in trainings and discussions related to the use of language and how it impacts stigma. So you being on this webinar and participating in this series is one simple thing that you're doing right now to learn more about HIV, and staying up to date on advances in HIV prevention and care. So I'm going to share a couple of infographics with you. And these come from the Stigma Project, which was a really cool project that came out about 10 or so years ago. And they've put out a bunch of really nice infographics about HIV stigma. So a lot of times people are confused about when to talk about AIDS versus HIV, because a lot of us grew up hearing only about AIDS and how AIDS did this, that, or the other, and was a death sentence, right? So we've learned now that really there is a difference between HIV and AIDS. So if we're talking about HIV, let's call it HIV. Try to avoid calling it AIDS unless the person is known to be at a late stage HIV diagnosis, which could be referred to as AIDS. In every other circumstance, we're talking about HIV. We're not talking about AIDS. We still hear died from AIDS a lot too. And the reality is that HIV and ultimately late stage HIV can cause opportunistic infections that will lead to death because of a compromised immune system. So the person is actually dying from an AIDS-related illness. They're not dying from AIDS itself. And the reason this is important to consider is when we keep saying they died of AIDS or they died from AIDS, we're perpetuating that stigma that HIV is a death sentence. And it's really not. The opportunistic infections that a person can get could lead to death. But the reality is that most people living with HIV now are living long, healthy lives. The last thing to consider is when we talk about people. So anytime you're thinking about, these things like an HIV patient or an AIDS patient or an AIDS victim, try to think about it as actually being a person living with HIV. There are many ways and many places where this could crop up. But again, when you think about person-centered language, it's not just a person living with HIV. It could be a person who injects drugs, or a person who uses drugs, or a person who has multiple sex partners instead of a promiscuous person, which I've heard people refer to before. Always think about centering the person and putting that first rather than the thing, whether it be the behavior or the illness or whatever it is. HIV disclosure etiquette. So if you're working with a client and they disclose that they have HIV to you, here's a kind of helpful tip sheet of things to consider avoiding and things you might want to consider saying instead. So yes, asking questions about HIV is important to learning and understanding it, but there's a time and a place. And so if you're working with someone who discloses, it's not a good time to ask things like, how long do you have? How did you get it? Who gave it to you? Some of these things like this that are clearly stigmatizing, but rather listen to the person that's in front of you. I'm here for you. I appreciate you telling me that. You can talk about treatment options. You're not alone. Those are the types of things that are much more helpful to say than really asking some of these questions that are in this left-hand column. Sometimes we hear the term full-blown AIDS, which again, there is no such thing as full-blown AIDS. There's no such thing as half-blown AIDS. So it's really just AIDS. If a person has a late stage HIV diagnosis, it would be considered AIDS. It's not full blown. Certainly, if a person has an opportunistic infection, there may be some conditions that they're going through that may put them at pretty significant risk for death, but that still doesn't mean that they're full blown with AIDS. It's just refer to it as what it is. This one I thought was interesting. So a lot of times we hear about like the war on AIDS or battling AIDS. And, you know, another way to think about that is the response to HIV or the response to AIDS or addressing HIV instead of fighting it. And that's because some of those terms may be considered militaristic and may lead others to think that people living with HIV should be fought or eliminated. And that certainly becomes a problem when a person hears someone say, oh, I'm fighting AIDS or I'm working on the battle against AIDS. And they might take that to mean you're fighting them or you're battling against them, which again, I'm sure you've all heard that impact matters more than intent. So even if the intent may have been, no, we're talking about the virus, the impact on creating stigma in a person living with HIV could be worse than what you may have intended. So I also have an infographic that has some other terms and phrases that are out there that we hear sometimes related to HIV, along with some suggestions of different language that could be used instead. So I'm going to drop that in the chat box for you all to take a look at. Let's see here. I'm just pulling it up now. So it should be in the chat box now for everyone to pull up, and feel free to print that out, use it, look at it. I think it's a really helpful tool. And here are some other resources that I have related to HIV stigma. The Stigma Project's website is a great place to pull out some of those infographics. There's also a stigma fact sheet from Act Against AIDS. And there's a global information and education on HIV, stigma and discrimination website there too. I also have another one. There's a stigma toolkit that NMAC created that may be valuable to folks. And so I'll send that link out also after the presentation. And this is really what it boils down to, right? Is we're not in 1984 anymore. So we can update the language we use and really consider how it can have an impact on people living with HIV. All right, so for the last part of this presentation, I'm going to focus in on HIV testing and treatment options. So how is HIV diagnosed? Testing is the only way that you can really know if a person is living with HIV. Testing is a huge part of our strategy at the state level and also at the federal level to address HIV. We have a really significant testing apparatus available in the state where our health department actually pays to provide rapid HIV testing to several different community-based organizations around the state. And obviously pre-COVID, those agencies were also able to go out and do work directly in communities. They were able to go to treatment centers. They were able to go to pride events and various other locations, meeting the community where they are for testing. As I said earlier in the presentation, the CDC does recommend routine voluntary testing. It should be a part of medical care for anyone between 13 and 64 years of age. Everyone in that age group, they recommend be tested at least once in their life. But if you are at higher risk for HIV, then certainly annual testing is recommended. The benefits of HIV testing, well, first of all, you learn your HIV status. You can get counseling on risk reduction. You can get access to treatment if the test is positive. And then ultimately, you reduce your risk of passing HIV to partners. There are two types of HIV tests that are out there that we use. One is a screening or rapid test, and that's usually done with just a finger stick. It takes out a little bit of blood from a person's finger, and usually the results are available anywhere from 15 to 20 minutes after the test is run. There are some rapid tests on the market that also will give you the result in as little as 1 minute. So it's a pretty incredible tool to use, especially out in the field and working with communities that maybe aren't interested in waiting multiple days to get their test result. So the other type of test that's out there is a confirmatory test, and that is done by drawing a person's blood. And that's a lab-based test. So that is probably the one that you'll see when you go to your doctor or a clinic. There is also a requirement that if a person has a reactive rapid test, that they then would have to get a blood draw confirmatory test from a lab. So screening rapid tests are useful to identify if someone might have HIV. It's not going to be the final result. So these screening tests are highly sensitive, and it is possible to get a false positive. And that's why we require anyone who gets a reactive screening or rapid test also get a lab test done to confirm that the rapid result was accurate. If the rapid result is negative, there's no need then to do a lab test. Confirmatory tests confirm whether someone who has a reactive or positive screening test has HIV. They're very specific and they identify only someone who has HIV. So this is actually, there are 3 different lab tests that we have available to us in the state of Wisconsin, and they can detect HIV as soon as 10 days after the person was exposed. If a person has a negative HIV rapid test, then that means that the person likely does not have HIV, or it could also mean that the client tested too soon after their last exposure. So what I'm referring to is the window period of the test, and every medical test has a window period. So that's the time between exposure to HIV and when the test is capable of identifying HIV in the person's body. There are no tests available, either rapid or lab-based, that can detect HIV sooner than 10 days after the person was exposed. So that obviously presents some challenges if, for example, there was a sexual assault or a rape that occurred. The person who was the survivor of that would not be able to be tested for HIV for 10 to 15 days after that event occurred to know whether that resulted in an exposure. They can be tested immediately to see whether or not they were negative prior to that event occurring, but the window period doesn't allow us to actually test anyone for a very recent HIV exposure. If the screening or rapid test was reactive, then the confirmatory test is positive, then the person is diagnosed and living with HIV. this would be the scenario in which the HIV result has to be reported to the state health department. So switching gears a little bit, I do want to bring up a couple of treatment advances in biomedical interventions. And certainly you will have an opportunity to dive deeper into these over the next 2 weeks on the subsequent webinars. So when we talk about biomedical interventions, those are medical, clinical, and public health approaches designed to moderate biological and physiological factors to prevent HIV, reduce susceptibility to HIV, and or decrease HIV infectiousness. So basically using biomedical tools to either prevent or treat HIV. For people living with HIV, the biomedical interventions are treatment adherence. And for people who are at risk for HIV but who are negative, we have nPEP, or non-occupational post-exposure prophylaxis, and PrEP, which is pre-exposure prophylaxis. So a couple of terms that you should be familiar with when we're talking about biomedical interventions and treatment. The first one is ART, or Anti-Retroviral Therapy. So HIV is a retrovirus, which means it carries its genetic blueprint in the form of ribonucleic acid and copies itself in the DNA of a host cell or a T cell. So what does antiretroviral therapy do? It fights the virus in a number of different ways. And all HIV treatment right now that's available is antiretroviral therapy. CD4 is the glycoprotein that's found on the surface of immune cells, and that is the particular cell that the HIV virus targets for replication. And then a viral load is the amount of virus, that's the HIV virus, that's found in a person's body. And when a person living with HIV goes in for their regular appointments, they'll be tested on a CD4 count and a viral load count. So ideally, if a person is successful in their treatment, they will have a low viral load count and a high CD4 count. If it's the opposite, if they have a high viral load count and a low CD4 count, that's a cause for concern. When we talk about viral suppression, that means that the amount of the HIV virus that is in the person's body is suppressed to 200 copies of the virus per milliliter or less of blood on a lab test. And actually, if the treatment, the ART treatment is successful, we can even get to a point where a person is undetectable. And that would mean that HIV is not detected in blood by any standard lab test. And that's often achieved after 6 months of consistent ART use. Undetectable and viral suppression is ultimately the goal of all HIV treatment. There are benefits to starting ART early. So the CDC, NIH, and WHO all recommend starting ART as early as possible after a diagnosis. So even if a person was just diagnosed, they can start antiretroviral therapy as soon as possible. That means that will result in a lower risk of illness and death. And there's no increased risk of side effects or toxicity to starting antiretroviral therapy early. And the reason that this is all important and the reason this is considered a biomedical intervention is because of what's called U equals U, or undetectable equals untransmittable. This is a huge advancement in the science around HIV treatment that basically says that people living with HIV who are on antiretroviral therapy with an undetectable viral load have a negligible risk of sexual transmission of HIV to sex partners. So that is why getting people on treatment is so important. And ultimately, going back to what I was saying earlier in the presentation about our viral suppression rate in Wisconsin, which again is at 75%, the higher that is, the more people that are undetectable, the less likely it is that they will transmit HIV to their sex partners. And again, trying to connect the dots here, you remember that the main mode of transmission of HIV in Wisconsin is male-to-male sexual contact, or penis to vaginal sexual contact. So if a person is undetectable though, and that type of contact occurs, the virus can't be transmitted. So that's a huge advancement, and it's so important that we spread the word about U equals U. And so how long does it take to get to that? Well, this is from the NIH, and basically to start off with, a person who is just diagnosed with HIV usually will have a very high viral load. And then when they start taking HIV treatment, within the first 6 months, they will achieve an undetectable viral load. They have to keep going in to their doctor's appointments to get those tests done to make sure that the medication is working. But within 6 months, they should achieve an undetectable viral load if they take that pill every day as prescribed. Then within an additional 6 months, they'll maintain the undetectable viral load after that first undetectable test result. And then at that point, there is effectively no risk of transmitting HIV to a sexual partner as long as you continue treatment and maintain an undetectable viral load. So just to sum it up, there are lots of benefits of antiretroviral therapy for people living with HIV. The preservation and or restoration of immune function to normal levels, improvement of overall health, longer life expectancy, suppression of viral replication, and effectively no risk of sexual transmission of HIV to partners. Those are all of the benefits of antiretroviral therapy for people with HIV. And here are some resources that I've included related to viral suppression and HIV treatment. So if you want to dive a little deeper into some of the science behind undetectable equals untransmittable, these are some good places to go. So now I'm going to briefly touch on some biomedical interventions for people who are HIV negative. First one is nPEP, and that is non-occupational post-exposure prophylaxis. It has to be started within 72 hours after a recent possible exposure to HIV, but the sooner the better. It's most effective when it's started within 48 hours of the possible exposure. The post-exposure prophylaxis is a pill that must be taken once or twice daily, depending on which medication is prescribed, for 28 days. And it's only going to be effective if it's taken once or twice daily for the full 28 days. And during that time, it's also necessary for the person to go in and see a doctor to monitor, be tested for HIV, because again, we're going to start the post-exposure prophylaxis within 72 hours of the exposure. There's no HIV test that would be able to pick up whether or not the person actually was infected with HIV during that time. So it's necessary for the person to go back in, usually at least once, but sometimes twice or 3 times during their course of treatment for PEP, to be tested for HIV, and then also to make sure that the medications are not having any adverse interactions with your body. A healthcare provider or emergency room can prescribe nPEP. It is totally a myth and not true that a place is not allowed to prescribe nPEP. This is unfortunately something that I'm hearing a lot out there from some health systems that say they don't have it or they can't prescribe it or whatever. The reality is that any medical doctor or emergency room can prescribe post-exposure prophylaxis, as long as it's done within 72 hours after a possible exposure. If the person comes in and they were exposed, 4 or 5 days ago, then unfortunately nPEP is not an option for them. It wouldn't be effective. And in that case, we would have to wait for that 10 to 15 days for them to get tested for HIV. And then, what that test will show us is whether or not the person was infected with HIV from that exposure. The CDC says that nPEP should only be used in emergency situations. And what that really means is you shouldn't go in after every single sexual encounter and ask for PEP. It is not intended to be used as a preventive method after every possible sexual encounter that may have led to HIV. It should only be used in emergency situations. For a person who is concerned about their HIV risk, PrEP or pre-exposure prophylaxis is a much better option than nPEP would be. There are a lot of really good resources about nPEP. Of course, you'll be hearing more about it next week at your next webinar and in the week after that as well. But these are some fact sheets, and there is also a patient assistance programs for PEP and PrEP document there that I've linked. And that, I know you mentioned that there are challenges with the costs of the medications. And that is absolutely right. These medications are really expensive, ridiculously so, if I may say. And there are, fortunately, patient assistance programs that the drug manufacturers do offer to cover the full cost of the medications. It just requires some help. A lot of times patients are not able to navigate these systems on their own. So it's important that folks who are working with the person, whether it be you or whether a case manager or someone else, a PrEP navigator is able to help them navigate that. PrEP, as I mentioned before, is pre-exposure prophylaxis, and it is a way for people who do not have HIV but who are at risk to prevent HIV by taking a pill every day. The pill does contain 2 medicines, and those 2 are used in combination with other medications to treat HIV. So PrEP, the medications that are in PrEP were actually used to treat HIV, but when taken on its own, it can also be used to prevent HIV. The name brands for PrEP that are out there are Truvada and Descovy. However, we also now have one generic option that's available that's manufactured by Teva Pharmaceuticals. There are expected to be multiple generic options available later this year, which will drive down the cost of PrEP significantly. PrEP is effective. It's 99% effective at preventing HIV when taken consistently. Certainly some people have what are called seasons of risk, where they may not need to take the pill once a day, every day, and they may just take it sometimes. And that's fine too, as long as it's taken consistently, it's effective at preventing HIV. It's less effective though if you're not taking it. So if you just take one pill and then wait 5 days and then take another one, it's not going to be as effective at preventing HIV in that type of a case. No studies found any significant safety concerns with the use of PrEP either. There are some barriers to PrEP access, but the barriers here are really just barriers that could be set with any preventive method and dealing with the healthcare system. So requiring medical visits, labs, and a prescription could be a barrier. Lack of insurance could be a barrier. Stigma, lack of provider awareness, and cost. we're working on addressing these barriers, and we've got advocates at all levels who are working on addressing these barriers. But these are really the reasons why PrEP hasn't taken off in a major way. And here are some PrEP resources that I just want to point out to you as well. So my key message here, if I can leave you with this in the last minute, is that HIV prevention is multifaceted. So testing, condoms, and biomedical interventions for both people living with HIV and people who are at risk for HIV but are negative can all work together to reduce HIV rates and improve outcomes on the HIV care continuum. That was all I had today. I do appreciate you all sticking with us for the entire hour and a half. And yes, Kimberly, you are correct. So Descovy was only tested in those assigned male at birth. And yes, the commercial is definitely very, very, very prevalent on TV right now. And honestly, though, what I've got to say is most insurers are only providing coverage for the generic option. And the generic option is not the same as Descovy. It's based on Truvada. And Truvada is effective in people who were born female at birth, along with trans folks as well. So most insurers now are requiring prior authorization for a person to be on Descovy. And the only reason that would happen usually is because Descovy is, if a person has some kind of a kidney function challenge or other underlying health issue, they may be prescribed Descovy for PrEP instead of the generic Truvada. My email address is on the slide. I know it's a little hard to see because it's blue on blue, but it's basically just my name at wisconsin.gov, jacob.dougherty@wisconsin.gov.
We'll be sure to include your contact information when we send out the materials, and we'll also include that PDF that you attached in the chat just in case folks weren't able to access it, because I know sometimes getting files from the chat in Zoom can be a little tricky.
Yeah.
Are there any other questions for Jacob? And I know there was a ton of information. You know, Jacob shared with us that the presentation from today is something that is days worth of information, and there's information that he didn't cover. So if things do come up after the fact, Jacob, you'll have Jacob's contact information, but you're also more than welcome to contact Sarah or I, and we can reach out to Peter and get your question answered, because everyone's situation will be different. So that's, you know, something that could come up a year or two down the road. So please don't hesitate to reach back out if you have any other questions.
Yes, thank you so much, everyone. I really do appreciate your time today. And I also appreciate your interest in learning more about HIV. And I think that you're all doing really incredible work. So thank you.
Thank you, Jacob. We appreciate your time. Also, just a plug, I don't know, Peter, if you can post the registration links again. We are very excited to have this webinar series happen because we understand that and I love that you pointed out earlier, Jacob, that anyone can be impacted by HIV, that we need to get past the stereotypes of whom we think is impacted by this. And I think that translates very easily into the work that you all are doing every day, which is why we think this is important for advocates to understand. And so we kind of made this webinar series in an easily digestible format, in that we broke it down into HIV basics and then PEP in basics for next week. So if you have any specific questions, please do come prepared for Ruthie and Joanna. They will be more than willing to to answer any of your questions. And then again, Amanda, for the last webinar on April 6th, will be referring to what your role is as an advocate, how you are best able to support the folks that you're working with in the field when it comes to HIV and access to PEP. So please feel free to register for those. And if you have any questions in the meantime, don't hesitate to reach out.